This episode of the Washington Manual of Surgery podcast will be bittersweet for many of us at WashU and in the world of pediatric surgery, as it features Dr. Brad Warner, who suddenly and unexpectedly passed away on April 4th, 2025. Dr. Warner was a remarkable surgeon, scientist, educator, mentor, and friend who served as chief of pediatric surgery at WashU Medicine from 2007 to 2023. He had a truly deep and lasting impact on surgery at WashU. If you had the pleasure of knowing him, you know that Brad was kind-hearted and forever dedicated to his patients and his trainees. Listening to this episode reminds me of the deep joy that he had for education and positively impacting everyone with whom he worked. We chose to release this episode in one longer version in honor of Dr. Warner's legacy and everything that he has done for academic surgery and surgery at WashU Medicine. To learn more about his life and legacy, please read the obituary linked in the show notes. Thank you, and I hope that under these circumstances that you can still enjoy and benefit from this episode.
The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast.
Hello, everyone, and welcome to the Washington Manual of Surgery podcast. We bring you everything you need to know about high-yield general surgery topics built for your just-in-time learning. On this episode, we are thrilled to have Dr. Brad Warner here to review the management of all things pediatric surgery.
Thanks for having me. Glad to be here.
Dr. Warner is the Jesse L. Turnberg, MD, PhD, Distinguished Professor of Pediatric Surgery and the former Chief of Pediatric Surgery at St. Louis Children's Hospital. My name is Horacio Carvajal. I am a PGY2 General Surgery resident and will be your host for this episode. On today's episode, we will discuss some of the most common causes of bilious emesis in neonates and infants. The goal of today's talk is to identify scenarios requiring emergent surgery, as well as the necessary preoperative workup and management strategies. Let's dive right into a case scenario to guide our discussion. A 4-week-old baby presents to the ED with lethargy, abdominal distension, and 1 day of bilious emesis. What are some of the things you would like to know on history and physical, and is there any additional imaging that you would like?
Many things I'd like to know, to include, has the baby been having normal bowel movements? Did they pass meconium in the first 24 to 48 hours of life? Has the child been eating fine until this point, or has it always been throwing up bilious emesis? And those would be sort of the big things.
Thank you, Dr. Warner. Those are some great points to bring up. So if the baby had been passing meconium and having normal bowel movements, what would be on your differential?
So the big thing about bilious emesis in a newborn in particular, the biggest thing you'd worry about is a midgut volvulus. And that would be an acute onset of bilious emesis in a child who's otherwise doing well. In this case, it would be abdominal distension, so it might be a little bit later. Typically, a baby that has an acute volvulus, there's not a lot of abdominal distension, and they're throwing up bile because the obstruction is really at about the third portion of the duodenum. So there's not a lot of dilated bowel that takes place in this situation, unless it's long-term. And then the bowel that's been volvulized begins to fill with fluid and gas and becomes more and more distended, and that's a very bad scenario, obviously. So first things first, I'd think of a midgut volvulus, and that would be a surgical emergency until proven otherwise.
Okay, so what would be the first imaging or labs that you would get for this patient?
Well, I think probably the most important thing to rule out the diagnosis of a midgut volvulus would be an upper GI, and that should be obtained pretty stat, unless the child needs some fluid resuscitation, and probably it sounds like this child does. So I think probably start an IV and probably 10 to 20 cc's per kilo of lactated ringers would be totally appropriate, and then maintain an IV fluid rate. At the time you draw or start your IV, we would typically send off labs, and things that I would look for would not be necessarily diagnostic of what's causing the obstruction or the bilious emesis, but it would be helpful to know just how sick the child is. So serum electrolytes, BUN creatinine, CBC, and coag studies, PT, PTT. Those would be the major things that I'd be looking at.
And let's take it back a step. And if the baby had not passed meconium, what would be on your differential?
So several things, one of which would be a Hirschsprung's disease. And that would be sort of fitting with this scenario with the abdominal distension, because the obstruction's typically at the rectus sigmoid region, and the bowel proximal is very dilated. The bowel that's beyond the aganglionic segment of bowel is collapsed and in spasm, and that's the obstruction. So classically, a child would not pass meconium in the first 24 to 48 hours of life. They may have an intermittent stool, small stool, and feeding, but then ultimately the obstruction would turn into bilious emesis. So that would be a hallmark of Hirschsprung disease diagnosed late.
Okay, and how would your approach to this infant without meconium change compared to the baby with the suspected midgut volvulus?
So I think plain abdominal radiographs would be a really important thing to start with for both imaging or for both conditions, because one would give you multiple dilated bowel loops and perhaps a dilated colon down to the area that's partially obstructed. That would suggest Hirschsprung's disease. A nonspecific gas pattern is pretty typical of patients that have a midgut volvulus because it's an acute twist of the bowel, and they really haven't had time to develop any gaseous distension or anything like that. That would occur late. So plain abdominal radiographs is a good start. Obviously, if you see something like free hair, that would be of concern for perforated viscus of some sort, and that would be very unusual in a baby, particularly a term baby at 4 weeks of age. But some of the other things that we think about, bilious emesis may be the first appearance of necrotizing enterocolitis in typically a premature baby, and you would look for pneumatosis intestinalis or portal venous gas, those types of things, or even free air in a baby that has bilious emesis.
All right, so we get our upper GI study, and it shows a bird's beak. What would this image suggest?
Well, that would be pretty classic for a midgut volvulus, and typically would occur, it says a bird's beak because it looks just like that, it's pointed. Sometimes we would see a duodenal atresia in a newborn, and that would be a more rounded obstruction, not a bird's beak appearance. So the bird's beak would tell me it's a volvulus, and that kid needs to go to the operating room emergently.
All right, so we resuscitate his IV fluids, and what other steps do you take between the OR and the ED?
So probably set up at least a type and screen, and I would administer IV antibiotics, some broad spectrum, probably ceftriaxone, Flagyl, or even a single dose of cefoxitin preoperatively. That would be pretty much it. Get a nasogastric tube down to help decompress, but that kid really needs to get to the operating room urgently.
All right, so we're in the OR now. What's the first thing you want to do?
So after prepping and draping, typically we'd make a right upper quadrant transverse incision and carry that down through the subcutaneous tissue, all muscle layers, and opening the peritoneal cavity. The next step then is to really eviscerate all of the small intestine so that you can see everything, see what it looks like in terms of color and perfusion. Typically, the volvulus will twist in a clockwise manner. So the way to remember which direction to untwist is think of turning back the hands of time. So you're untwisting the bowel in a counterclockwise manner. And that could be confusing because sometimes you will see the bowel and it'll all be dark and dusky, even purple sometimes, and you don't know which direction to turn because it's just a wad of bad-looking bowel. But if you start going in a counterclockwise manner, that'll typically untwist it. Once it's untwisted, then you want to characterize whether that bowel is going to reperfuse or not. And if it's dusky and it stays a little dusky, then probably not do anything on that operation, but probably plan on a second look procedure, and you could either close skin alone or put a wound vac on and bring them back 24 hours later to see if the bowel has pinked up. The overall goals here is to preserve as much intestine as possible. So if there's any potential that it's going to recover, that's what you would want to do. If there's obviously dead bowel and it's not going to be recoverable, then we would probably resect the segments of dead bowel. If the child was not doing well or a little unstable, I wouldn't probably do an anastomosis at that time. Probably tie off the ends of the bowel after you've resected the component that's dead, put it back in, and come back in a couple of days after the child's been more fully resuscitated and is beyond the period of sepsis. So the LADS procedure, though, let's assume that the bowel is not dead and you've untwisted it and it pinks up nicely. So now what you're dealing with is in a typical non-rotation, and that's the most common abnormality. The duodenum and the ascending colon are essentially fused together. And when you separate those two structures, what's running right down the middle of that is the superior mesenteric artery, and that's supplying blood to the entire small bowel. So if you think of the duodenum and the colon as being a sort of a fulcrum by which the small bowel can twist on the top, then it's like the golf tee, if you will. A golf tee with a ball sitting on the top. The ball is the small intestine, and that can twist. But that tee is really where the blood supply is coming in from. So what you want to do is divide LADS bands, which are bands that run from the retroperitoneum over the duodenum, over the colon, and those are fused together. So you do a generous Coker maneuver on the lateral aspect of the duodenum all the way up to the portal triad. And then you also then separate the medial bands from the colon and duodenum. So you're widening that mesenteric base. So you're preventing the ability to twist. So that's a really important part of it, is to broaden the mesenteric base. And then the final thing that we do before replacing the bowel back into the peritoneal cavity is we typically would take the appendix out. And the reason is because when we put things back into the abdomen, the appendix is not going to sit in the usual right lower quadrant. And so if a child would get appendicitis in the future, they would be misdiagnosed. And then you replace the bowel and you put all of the colon to the left and all of the small bowel to the right, and then close.
So for the appendectomy, do you always do that, or are there certain patients in whom you would opt not to do an appendectomy?
In a straightforward LADS procedure, yes, I do an appendectomy pretty routinely. And it can be done several ways. You can do it as a standard appendectomy where you divide the blood supply and then tie off the appendix and then divide it and remove it. Another thing that we do in patients with this type of condition is we'll do an inversion appendectomy where we actually resect the mesentery going to the appendix. So now it's devascularized. And then you can put a little probe at the very tip of the appendix and push that into the lumen of the cecum and then tie it off right as it goes into the appendix. And the kid will usually stool that out in a few days. It's not anything anybody ever sees or identifies because by the time it's passed, it's become pretty much liquefied and dead.
And what are the outcomes of these straightforward LADS procedure?
They're actually pretty good. I think the recurrence rate for a volvulus is probably on order of 3 to 5% max. If a child has had a prior LADS procedure and comes in several years later with a bowel obstruction, it's much more likely that their obstruction is due to adhesions than it is due to a recurrent volvulus.
And in the long term, what risk factors do these patients face?
Pretty much the major ones would be a volvulus, recurrent volvulus, and or adhesive small bowel obstruction. So the things to tell the family is if they have any bilious emesis again or severe abdominal pain, abdominal distension with obstipation and things like that, they should be seen rather quickly in the emergency room.
Okay. And in the case of a non-straightforward LADS where you had to resect plenty of bowel, when do you do an ostomy instead of going back and reanastomosing for these patients?
Yeah, that's a good question. I think in general, I would try to keep the intestinal continuity get intestinal continuity established as quickly as possible, especially if they've got a proximal segment of bowel that's, been removed, and giving them a proximal ostomy, you're not really helping that child very much. I would say probably under most circumstances, I would do a primary reanastomosis after the child has done well. If they're doing okay on the table and everything is good, then I would just do it right then. But obviously, if there's a lot of bowel that we need to have a second look at, or if the child's struggling hemodynamically and having issues, then I think just leaving it in place. So I may do an ostomy if it was going to require a colonic anastomosis, perhaps, or a small bowel to colon anastomosis that I didn't feel very good about. So it's basically clinical judgment, really.
And do you worry about short bowel syndrome in these babies?
Oh, I absolutely do. And that's the rationale for getting to the operating room urgently, is because you really don't want to allow them to lose all of their intestine. So, yeah, midgut volvulus is a important cause of short bowel syndrome in patients. And so you try to preserve as much intestinal length as possible by getting to the operating room quickly and going for second look procedures to not take out bowel that otherwise might have survived. But short gut is really a major problem.
Thank you so much, Dr. Warner. This is all very helpful. Let's talk a little bit about more distal causes of bilious emesis, particularly Hirschsprung's and meconium ileus.
Mm-hmm.
In these babies, say it's a 3-day-old infant, bilious emesis, distended abdomen, has not passed any meconium, what would you be worried about?
That would include Hirschsprung's disease. It would include meconium plug or meconium ileus, or it could be a colonic atresia, or it could be an anorectal malformation where they have an imperforate anus.
And how would you work these up?
So really, I think external physical examination would be really important to start with. Make sure they actually have a patent anus, and that's very important. The other thing is to do a digital rectal examination with your small finger to make sure that there's no rectal atresia or what type of contents come out. If there's meconium-like stool, then probably an atresia would be ruled out because that would occur in utero and they wouldn't be able to have much in the way of meconium very distal. And so if you get just mucus or something, that would suggest a potential for an atresia. And then basically the abdominal distension, if there are palpable bowel loops and those types of things, would suggest chronic long-term obstruction that would be distal. I think a plain abdominal radiograph would be really important because there are some features suggestive of meconium ileus that you could pick up on. One of which would be, there's 3 things that I remember with meconium ileus in the plain abdominal radiograph. One of which is a gaseous sort of mixture like foamy gas pattern, spiculated gas, and that's meconium mixed with gas in the bowel. The other is absence of air fluid levels, because the meconium is like tar, and when you have an upright plain abdominal radiograph, it won't layer out. It just stays on the sidewall of the bowel because it's so viscous. And the other thing is you may see calcifications scattered throughout the peritoneal cavity, and that would be consistent with a very complex meconium ileus where there's been an in utero perforation or an in utero volvulus of the bowel. And the calcifications are really saponification, calcium being laid down in the context of inflammation and scar.
And in this baby with meconium ileus, what other pathologies would you be worried about?
Well, the big thing would be cystic fibrosis, and that would be the biggest one that would be associated with meconium ileus. And so that would definitely need to be worked up. That's typically done with, there's genetic testing for meconium or for cystic fibrosis. And that covers a good amount of the mutations, but not all of them. So the gold standard, if you're really concerned, is a sweat chloride test. And that's done on the skin and determine that the sweat chloride levels are very low.
And what would the best treatment be for a meconium plug? And in what instances would you take this baby to the OR?
So I think for a distal obstruction, many times you're not sure whether it's like a Hirschsprung's potential or it could be a meconium plug. The other things to consider would be a microcolon associated with mothers of infants or infants of diabetic mothers or mothers that have had mag sulfate, that they can have a neonatal small left colon syndrome. And that's more of a motility factor. But all of those sort of may look the same on a plain abdominal radiograph as the distal bowel obstruction. So I would start with a water-soluble contrast enema from below. And the things that you look for in Hirschsprung's would be you would see a collapsed, narrowed rectum with more proximal colon dilated. And going from that proximal colon to the narrowed part is sort of a segment called the transition zone. And so that's where you look for, is the transition from the collapsed distal bowel to the dilated proximal bowel in Hirschsprung disease. In someone with a meconium plug, you would see, I guess, plus or minus a microcolon, but you would see a big luminal foreign body in the rectum, and that would be the plug. And typically that would be both diagnostic and therapeutic, because once you administer the enema, they pass the plug. And if all's good, then they start pooping like crazy. It's like popping the cork off a champagne bottle. So that can be really rewarding for the baby and you, if you're into watching that kind of thing. But it is rewarding, and they pass the plug, and that's really all that they need. But about 9% of patients that have a meconium plug will also have Hirschsprung's disease. So they do coexist sometimes. So typically, if they passed a meconium plug from an enema, then we follow those patients. If they continue to stool and look well, we wouldn't do anything further. But if they have continued problems with constipation or abdominal distension, then we would pursue a further workup of Hirschsprung disease, and that would involve a suction rectal biopsy. And we would be looking for ganglion cells, we'd be looking for hypertrophic nerve cells, and there's an calretinin staining that sometimes is also done to determine whether there's aganglionosis or not. And in someone with a meconium ileus, you would see a microcolon. You'd fill the entire colon. There wouldn't be much in the lumen of the colon, but what you'd hope is to reflux back into the terminal ileum, which would be, that's the site of obstruction with all of the meconium. So you want to get all of that contrast into the TI, and that would help separate it from the wall of the bowel, and then they could start passing meconium, and you can relieve that obstruction just with serial enemas. And that's probably successful in about 70% of cases. So you can evacuate everything, and they can start stooling spontaneously, and that would be most helpful. And then, of course, they need the CF workup and that type of thing as well. But it's really important to be able to reflux it back into the terminal ileum. If you just did it in the colon, that would not be sufficient. Failure of decompression with an enema would warrant laparotomy. And typically what you would do in that situation would be identify the dilated small bowel, and you do an enterotomy, and you can irrigate out the small intestine lumen either with warm saline, or what most people would utilize is N-acetylcysteine or Mucomyst, and that can be administered in a 4% concentration to the lumen of the bowel. And it's amazing how the meconium, which is like glue stuck to the lining of the bowel, separates completely with the Mucomyst, and it breaks down the disulfide bonds. And the stool then comes on out, and you can milk it out and get it completely collapsed. Most people at this point would then either close that enterotomy after you've evacuated all of the meconium. Some would leave a tube in the jejunum, because if they need to be evacuated again, you've got a jejunal feeding tube that would allow you to push more meconium or Mucomyst through the catheter and do that. I typically just do a closure. One of my partners does the tube. It used to be, too, that people would do various maneuvers of the distal ileum. They would do either a bishop coupe or a Santui type of configuration of the bowel. So a bishop coupe is you divide the bowel, you'd bring up the distal end as a stoma, and then you take the proximal end and sew that to the side of the bowel that's been exteriorized. And a Santui is the opposite. You bring up the proximal bowel, but sew the distal bowel to the side of the proximal bowel. So I think there's a lot of different ways of doing a stoma, but most people probably wouldn't do a stoma at this point. They'd either do a tube or just close primarily.
And going back to the baby with Hirschsprung's, you did the suction biopsy and it's positive for Hirschsprung's. What would your next step be?
So if we now have made the diagnosis of Hirschsprung's disease, there's several different options, and I think a lot of it depends on the experience of the surgeon. Some surgeons would do a pull-through in the neonatal period. And that would be in the context of a baby that's otherwise healthy, has no associated medical problems, doing well. And you would do this typically laparoscopic assisted because you want to absolutely know where the transition zone is. Because once you start doing the pull through the rectum, you can keep pulling through and not be able to encounter enough length and still no ganglion cells. So you want to be sure where that level is. And then laparoscopically, you can take down the mesentery all the way down to the peritoneal reflection and then do a resection from below transanal to meet your dissection from above, and then pull the bowel out that way and get to the level of where you determine that there are ganglion cells. And then you typically go 5 centimeters proximal to that. And then pull that down and sew that in place at the anus, and then resect the distal aganglionic bowel. So that would be a primary pull through in the neonatal period. Others with maybe not as much of experience or their own surgical judgment would do the pull through when the baby's a little bit bigger. And I think that's a very reasonable approach. That's what I do. And in those patients, they can be sent home on a program of rectal irrigations. And what that is it's not an enema. It's not where you just squirt some fluid up the rectum and leave. You really have to put a catheter up and inject slowly, typically saline, and push and pull the catheter to drain the fluid and stool out through the catheter or around the catheter, and also be pushing on the abdomen to push the enteric contents down through the catheter and all of that. So it's a process of washing out the colon actively. And so in advancing the tubing, injecting more saline, pulling it back, pushing on the abdomen, advance again, wash, that type of thing. And that's usually done 2 to 3 times a day until the child gets bigger. The problem with that is some families are not able to do that at home, and or the child is really born very small and you really couldn't do a pull through at that point. In those circumstances, we would do what's called a leveling colostomy. So they'd go to the operating room, and what we would do is intraoperatively send frozen sections to determine where the transition zone is, and then do an ostomy just proximal to that. So it's usually a sigmoid colostomy that's brought up. And then those patients can eat right away, go home, grow, and now you already know what the level is going to be. You're just going to take down the ostomy and do your pull through that way.
And what has your experience been in general with these babies? What's your preferred method?
I prefer letting them be around 15, 20 pounds before I do the pull through. So they typically, in my hands, would go home with irrigations. If they weren't doing well with irrigations, if the child was reasonably sized, then I would go through with a pull through. So I've done an ostomy periodically for kids that have come in with enterocolitis that aren't looking well, and it's a later diagnosis of Hirschsprung disease. So you really want them to be under the best conditions when you do your pull through. So in those circumstances, I think a colostomy is reasonable.
Thank you, Dr. Warner, so much for being with us today. This was extremely helpful, and we really appreciate the ton of great information you gave us about causes of bilious emesis and how to work them up in newborns. As always, if you're looking to learn more, you can check out some of the literature we referenced in today's episode in the show notes, and a full review of pediatric surgery can be found in the Washington Manual of Surgery's chapter on pediatric surgery. Thank you so much for being with us today, and I hope you guys enjoyed it.
Thank you.
We are Drs. Paul Wise
and Jeff Blatnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine, and we'd especially like to thank our associate editors for this edition, Drs. Catherine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zarate Rodriguez.
We hope that you enjoyed this episode of the Washington Manual of Surgery podcast. For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams & Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.